Thanks for coming to our resident research symposium. I'll kind of be the narrator for today and introducing all of our residents and their research projects. So first up, we have Dr. Kathleen White, and she will be presenting over pharmacist-led intervention to delabel penicillin allergies at an academic primary care center. Everyone, please welcome Dr. White.
Thank you. I have no conflicts of interest to disclose for this presentation. The purpose of this research project was to assess and delabel inappropriate or low-risk penicillin allergy labels among patients with penicillin allergy labels in an academic primary care clinic. The problem of inappropriate penicillin allergies is a global and also national issue. It is estimated that about 10% of the United States population reports a penicillin allergy. However, we also know from this data that greater than 90% of those patients can actually tolerate a penicillin antibiotic. These inappropriate penicillin allergy labels have negative ramifications. So these labels put you at greater risk for multi-drug resistant organism infections. They increase broad spectrum antibiotic use. They also prolong hospitalization and increase healthcare costs. And they're also associated with greater incidence of adverse drug events. We know that from the point of initial reaction, even patients that have a true or real IgE-mediated reaction, after 10 years, they can tolerate a penicillin antibiotic, representing a large proportion of patients that potentially may tolerate penicillin antibiotics, even if they had a severe reaction during childhood. As part of our research project, we incorporated the PenFast clinical decision-making tool, along with our other allergy assessment, which we'll talk about in more depth in the coming slides. The PenFast allergy clinical decision tool has very high negative predictive value, which is what we were using it for in this project. So it's very accurate at identifying allergy labels or allergies that have a very low risk of a true reaction. Based on the variables that they included in their tool, we know that we can calculate a score that correlates with a very low risk percentage. And we were targeting these 0 or 1 to 2 risk scores. They were looking mainly at the time since the reaction, whether it was a severe reaction such as anaphylaxis or angioedema, or a severe cutaneous adverse reaction, or if treatment was required for the reaction. Our study was conducted at the UT Family Practice Center. This is an academic family medicine clinic in Chattanooga, Tennessee. They have about 6,000 active patients and see about 110 patients per day. They also have a team of family medicine residents, faculty physicians, and 1 clinical pharmacist. And that leads us to our project rationale and goals. So we know that there are a large number of penicillin allergy labels. However, the proportion of trained allergy specialists to address these allergy labels doesn't meet the need for addressing these labels. We hypothesize that pharmacists are ideally positioned and trained to evaluate these lower risk allergy labels. The goals of this project were to design and implement a protocol to evaluate penicillin allergy labels, and then to also delabel inappropriate or inaccurate labels. We included any patient that had a penicillin allergy in the electronic health record, and this mainly consisted of adult patients, non-pregnant patients, non-incarcerated patients, and of course, just from the methodology that we used for our protocol, they had to be able to be reached via telephone. So we naturally excluded patients that did not have accessibility via telephone, that did not answer after 3 separate attempts were made to contact them, and patients that did not have clinical decision-making capacity. Our protocol was conducted in 3 main separate steps. So there was the pre-interview portion of the protocol, which mainly consisted of chart review. So we looked at all eligible patients with penicillin allergy labels, and we collected certain variables that were, 1, important for the interview, and then also important for describing this population. So this would include any EHR data about the allergy, which antibiotic it was to, what the reaction was, and if it was available anytime duration since the reaction. We also looked at any previous antibiotic use, and then looked at any other incidences of multi-drug resistant infections or a couple other variables. Which leads us to the interview. So for this part of the interview, we contacted patients via telephone, and we conducted the interview in four main separate steps. So step one would be consent. So we required all patients to consent to participation in the interview. And then we would conduct our penicillin allergy assessment algorithm, which we will spend more time on in the coming slides. We also calculated their PINFAST score to assist in our decision-making for whether to delabel the allergy label. And then we also looked at the patient's reported or tolerance of other penicillin antibiotics. As part of the interview, we included an education portion. So really, based on the information the patient provided us and what our recommendation was, we would provide education for what the patient should do moving forward and about their allergy assessment. So if we did choose to delabel, we would provide education on what that means for the patient and how to proceed moving forward, that they can tolerate penicillin antibiotics. If we referred them on for allergy assessment, we would educate on that as well. And then if they should continue to avoid based on their risk of a severe reaction, we would also educate them on that. And then finally, the final portion of the protocol was documentation. So documentation of the interview in EHR via a progress note. We also documented patient consent to remove the penicillin allergy label, which was required to delabel. And then we modified the allergy label in EHR to include any relevant information within the allotted character size that would be relevant for future providers. This is an overview of our penicillin allergy assessment algorithm that breaks it down into the determined risk or severity reaction, and then also includes a quick, brief look at the PINFAST score. We were mainly seeking to delabel low risk, low severity reactions. And so this would include reactions such as GI intolerance, so nausea, vomiting, diarrhea. We also looked at family history of reported allergy. And then upon discussing with the patient what their allergy label was and which antibiotic it was to, potentially a lot of these patients would tolerate them and we would recommend delabeling of the allergy label. We also had a group of patients that we would put in our moderate risk severity reaction category. And so this would be patients that reported some kind of urticarial reaction, whether immediate or delayed. So that hives type reaction is really what we were trying to target here. So a potential IgE mediated reaction. These patients were typically not eligible for delabeling unless they reported tolerating amoxicillin in particular. We would also take into account when they had tolerated amoxicillin in relation to when that initial reaction was. And then finally, we have our high risk, high severity reaction. And these patients were not eligible for delabeling. So these reactions included any patients that reported anaphylaxis, angioedema, Stevens-Johnson syndrome, a TENS reaction, or other severe cutaneous adverse reactions. We started out with 615 patients that had penicillin allergy labels in EHR, and we were able to reach 239. Of this 239, we were able to recommend delabeling in 84 or 35% of these patients. 105 of these patients, or 44%, were recommended on for outpatient allergy assessment. And then ultimately 21% were determined to have high-risk allergy labels and were recommended to avoid penicillin antibiotics moving forward. Of the 84 that we recommended for delabeling, we had 61 that were actually delabeled, representing a high acceptance rate from our patient population. So because we are in an outpatient setting and we're not in an inpatient setting where we can directly test whether these patients can tolerate a penicillin antibiotic, we required consent to removal of the allergy based on the assessment prior to removal. So ultimately, we had reasonably high acceptance rate of that recommendation. This is a quick look at our baseline characteristics for our patient population. Of course, most patients reported just penicillin as the allergy or the antibiotic of origin, but we did have a good proportion of patients that reported an amoxicillin allergy. The most commonly reported reaction was actually typically this immediate urticaria or hives reaction. And there was a relatively smaller number of GI symptoms, with the most of those symptoms being in our recommended delabel cohort. Most reactions occurred greater than 10 years ago, so greater than 79.5% of our total patient population had reactions that occurred greater than 10 years ago. We did see a good proportion of patients that had documented EHR use of broad spectrum antibiotics, particularly clindamycin and fluoroquinolones. And then ultimately, we did see a good portion of patients that had reported use of cephalosporin antibiotics, but potentially lower based on their ability to tolerate these antibiotics. We only had one patient that reported a cephalosporin allergy. Taking a closer look at our recommended delabel cohort, we had 79.8% that had reactions that occurred greater than 10 years ago. We also had 75% of patients that reported tolerating another penicillin antibiotic or cephalosporin antibiotic. And of these patients, 63.5% actually tolerated amoxicillin upon discussion, representing a great group of people that could have been delabeled prior to our intervention as well, had this allergy been further characterized. Of our allergy reaction risk severity categories, we had a good portion of patients that were in that lower category and then also in the moderate category. And these patients were typically those that reported that urticarial reaction, but we were able to delabel based on amoxicillin tolerance. And then comparing our more conservative category protocol to the PINFAST score, we were more conservative in our approach, but according to the PINFAST clinically validated tool, most of these patients could have been delabeled with a score of 0 to 1. And then looking a little bit more closely at our referred for allergy testing cohort, again, we saw a large percentage of patients that reported these reactions occurred greater than 10 years ago. We had a smaller portion of patients at 47.6% that reported tolerating another penicillin or cephalosporin antibiotic, and an even smaller percentage that reported tolerating amoxicillin. So according to our more conservative protocol that emphasized safety as opposed to delabeling, we were not able to delabel some patients that reported tolerating amoxicillin if they tolerated another high-risk, high-severity reaction. And in this cohort, we did see a higher proportion of patients that reported a severe risk, highly severe reaction. We also see this reflected in our PINFAST score, which did identify more patients that reported that score of 3, which would be no delabeling, high risk of real reaction. But we also saw a good proportion of patients that were in that 0 to 1 category again. So kind of summarizing the takeaway points from our study, we saw that 65.7% of our overall population had a PINFAST score of 0 to 1. So according to this clinically validated assessment tool, these patients could have been delabeled and could tolerate penicillin antibiotics. So this represents that a majority of these patients could be delabeled based on this protocol. We were a bit more conservative because we couldn't directly test these allergies. We saw that 79.5% of patients reported these reactions occurred greater than 10 years ago. And as we know from previously presented data, that most of those patients can tolerate those antibiotics after 10 years. So again, another proportion of patients that could potentially go on to tolerate penicillin antibiotics. And then finally, we had 64% of patients report tolerating cephalosporins, which is important because we know from the data that providers are less likely to prescribe other beta-lactams if a patient has a penicillin allergy on their profile, meaning that our intervention was effective in further characterizing these patients that can tolerate cephalosporins and may improve cephalosporin utilization in the future. Moving forward, we hope to integrate this into the inpatient and outpatient setting, so a system-wide integration, and implement it into EHR. We are going to look at relabeling frequency in our patients after the intervention, and then also incorporate available allergy testing information for these patients as we learn about their results. And we actually did have one patient that went for allergy testing this week and was found to not be allergic to penicillin antibiotics as a result of our intervention. My assessment question is, the majority of penicillin allergy reactions associated with penicillin antibiotics occurred greater than 10 years ago. That's true. And I'll take any questions now. Yes. So Megan's question was, did I find that most patients were agreeable to talking about their penicillin allergy over the phone? Is that a good summary? In general, they were pretty receptive. There were, of course, some patients that were not super willing to have that discussion over the phone and just kind of or maybe a little bit hesitant with a pharmacist conducting that interview, just to be completely honest. But we did have a majority of patients that were willing to speak with us.
How long did it take you to conduct each interview? Just from a workflow standpoint.
Yeah, so Jessica's question was, how long did it take each interview to conduct? We didn't time the specific duration of the interview. However, just thinking back about how the interview typically progressed, it really maybe took 5 to 10 minutes. We used a smart phrase that was pretty streamlined to take you straight through the assessment, and you already have your answer by the time you're done speaking with the patient. Thank you all.
Alrighty. Next up, we will have Dr. Austin Dykes. And he will be presenting over the assessment of preemptive stop date applications on antimicrobial therapy duration in hospitalized patients with community-acquired pneumonia. Everyone, welcome Dr. Dykes.
Thank y'all for coming. I am excited to share the results of our research with y'all today. And with that, we'll get going. So first, I'll just start by saying that I have nothing to disclose in regards to this presentation today. The objective of today's presentation is to compare the total duration of antimicrobial therapy in hospitalized patients with community-acquired pneumonia, or CAP, before and after adoption of an active antimicrobial stewardship intervention. The Centers for Disease Control estimates upwards of 2.8 million antimicrobial resistant infections occur each year in this country, resulting in greater than 35,000 deaths. This, coupled with the fact that we have very limited development of novel antimicrobial agents, presents a real and present danger to public health. CAP is a very common infectious disease state, estimated to have an annual burden of 1.5 million hospitalizations each year on the United States healthcare system. And these patients often receive prolonged durations of antimicrobial therapy, which was seen in a recent study conducted on the behalf of the CDC, in which they saw greater than 70% of patients in this population received antimicrobial therapy for at least 8 days. And this is especially a problem at hospital discharge, where nearly half of this total duration has been accounted for. The American Thoracic Society and the Infectious Disease Society of America recommend antimicrobial therapy durations of at least 5 days for uncomplicated CAP. And this means that these patients don't have ICU requirements throughout their hospital stay, and they show quick effervescence upon treatment initiation. And this recommendation is supported by evidence showing that, in fact, patients treated with shorter durations of antimicrobial therapy show very similar outcomes to those treated with prolonged. And lastly, active antimicrobial stewardship interventions have shown to decrease the excess days of antimicrobial therapy across a myriad of indications. And these include things like prospective audit by the stewardship team and direct verbal feedback to providers, automated order entry limits on antimicrobial therapy via computerized systems, as well as a previous study conducted here at Erlanger that showed the usefulness of policy allowing the stewardship team to apply stop dates to antimicrobial therapy for patients that were receiving durations that exceeded recommended limits. So the purpose of our research was to examine the effectiveness of an active antimicrobial stewardship intervention on decreasing the duration of antimicrobial therapy in patients hospitalized with uncomplicated CAP. Our primary outcome was total duration in days of antimicrobial therapy, and we defined a day as any calendar day that a patient received at least one dose of an antimicrobial agent. And total duration was a summation of inpatient therapy and therapy prescribed, so days of therapy prescribed at hospital discharge. Our secondary outcomes included antimicrobial prescription duration at hospital discharge, excess days of antimicrobial therapy, which we defined as those exceeding 5 days, hospital length of stay, 30-day all-cause hospital readmission rates, and 90-day incidence of C. difficile and multi-drug resistant infections. So this study took place across the entirety of Erlanger's health system, which we know consists of 1 academic medical center and 5 outlying facilities. We have 797 adult beds across the health system. And we also boast a very progressive antimicrobial stewardship program in which an ID physician and an ID pharmacist review patients on antibiotics daily, not only to recommend therapy duration, recommend changes or sorry, I'm blanking on the word. Not only to optimize therapy durations, but to optimize the therapy that the patients are receiving as well. So our study was an IRB approved retrospective pre-post study. The patients were identified via an EPIC report that detected diagnosis of CAP and antimicrobial odor. Data was then collected through chart review, and for statistical analysis, our categorical data were analyzed using either a chi-square or a Fisher's exact test. Continuous data were analyzed using a Wilcoxon ranked sum test. And because we were comparing the 2 patient groups over several different variables, a Bonferroni correction was applied for multiple comparisons in order to correct for that. And after the correction, a p-value of less than 0.007 was thought to be statistically significant. So to introduce our study groups, we'll start with our intervention cohort. So these patients enjoyed an automatic 5-day duration of azithromycin that was set at the time of order entry if it was ordered for these patients. They also received a stewardship review and an application of preemptive 5-day stop dates on all other antimicrobial therapy. And then lastly, we left a note in each of these patients' electronic medical record to document our intervention, as well as to recommend to providers what their stop date should be if they were to discharge prior to day 5. This is in comparison to our historical cohort, which these patients received, if identified, stewardship audit and feedback, as well as an automatic stop on excessive antimicrobial therapy durations. And for community-acquired pneumonia, this is 7 days or more. We included adult patients with a general ward admission and a chief diagnosis of CAP in this research. And we excluded those who had any ICU admission throughout their entirety of their hospital stay, whether this was at admission or any point during their stay. Those with cystic fibrosis, empyema, or lung abscess. Immunosuppressed patients, and we define immunosuppression as asplenia, HIV positive with a CD4 count of less than 200, those who had a history of solid organ transplant, and those who had an ANC or an absolute neutrophil count of less than 1,500. We also excluded long-term care facility residents, and this did include nursing home residents. We excluded patients with recent hospitalization or treatment of pneumonia within the previous 30 days to their index stay. And then lastly, we excluded patients who had recent isolation of methicillin-resistant Staph aureus or Pseudomonas aeruginosa within the previous 90 days to the index stay. When we look at the demographics between the 2 patient cohorts, we see very similar numbers across, for the most part, across all of our different characteristics. But I will bring your attention to the fact that we did see a higher proportion of Caucasians in our historical cohort compared to a higher percentage of patients, Black patients in our intervention cohort, which was found to be statistically significant on comparison. And then for pre-admission comorbidities, we saw a very similar rate between the 2 patient groups, and most of the identified comorbidity or pre-identified comorbidities that we were looking for outside of those admitted with CKD, with our intervention cohort having a significantly higher rate of those patients. For our primary outcome of total therapy duration, we saw a difference of 2 days between the 2 patient groups, with our intervention cohort having a median total duration of 5 days and our historical cohort having a median total duration of 7. And this was found to be a statistically significant difference. For our secondary outcome of excess antimicrobial therapy, which again we defined as therapy durations exceeding 5 days, we also saw a significant difference between the two patient groups, with our historical cohort having a median of 2 days and our intervention cohort having a median of 0. And we also saw a significant difference between the two groups in regards to antimicrobial therapy prescribed at hospital discharge, with our historical cohort showing a median of 3 days, and again, our intervention cohort showing a median of 0. For the remainder of our secondary outcomes, we did not see a significant difference between the two patient groups. And this is in regards to length of stay, 30-day readmission rates, multi-drug resistant infection rates, and lastly, in-hospital antimicrobial durations. No patient in either group had a documented C. diff infection. And then lastly, I'll just point your attention to the top row there, the length of stay. And while we didn't see a significant difference between the two groups, I do think it's important to point this out, that our intervention cohort did have a 1 day longer median length of stay than our historical cohort. However, this could be simply explained by a selection bias because the patients in our intervention cohort had to be identified by our stewardship team in order to be included in that. So in conclusion, our active intervention was effective at decreasing total days of antimicrobial therapy in patients hospitalized with uncomplicated CAP. It also reduced excess days of antimicrobial therapy, as well as therapy prescribed at hospital discharge, and we did not see an increase in adverse events or hospital readmission rates. And so for our assessments, for patients hospitalized with uncomplicated CAP, the ATS and IDSA recommend at least how many days of antimicrobial therapy? Lastly, I would like to thank all of my co-investigators for all of their help and assistance throughout this process. And with that, I will open it up for questions.
Thank you, Dr. Dykes. That was an excellent, thorough presentation. Next up, we'll have Dr. Fabiola Lozano. And Dr. Lozano will be presenting on the comparison of prescribing patterns of non-insulin pharmacologic agents for type 2 diabetes between a pharmacist and usual care in a federally qualified healthcare center. Take it away, Dr. Lozano.
Thank you for that introduction. So first, I want to state that there are no disclosures regarding the information in this presentation. And I have listed here the abbreviations that are featured in the presentation for your reference. By the end of this presentation, the objective is to describe prescribing rates of first-line non-insulin therapies among patients with type 2 diabetes being managed by a clinical pharmacist compared to usual care. The emergence of SGLT2s and GLP-1s have revolutionized type 2 diabetes management, as they represent the only drug classes with evidence for reduced cardiovascular events and mortality in large randomized clinical trials. And the robust evidence has led to their incorporation into the guidelines as first-line agents for patients with chronic kidney disease, atherosclerotic cardiovascular disease, and heart failure, as seen in the 2022 American Diabetes Association and the 2020 American Association of Endocrinologists guidelines. However, our underserved populations face several healthcare barriers, including language, physical, and socioeconomic barriers, which leave many of these patients without financial means to afford these novel medications. Federally qualified health centers are community-based health centers that provide comprehensive primary care to a wide range of underserved populations. They receive funds from the Health Resources and Services Administration to offset the cost of uncompensated care in underserved areas based off of the achievement of specific quality metrics, which includes an A1C less than 9% for diabetes management. Multiple studies have demonstrated that incorporating a clinical pharmacist in these primary care settings result in improved outcomes by identifying and addressing gaps in healthcare, helping patients achieve glycemic goals, and clinics reach national standards and minimize costs by assisting patients access 340B priced medications, helping them fill out patient assistance programs, and identifying manufacturer or copay coupons. A recent study conducted in 2019 compared pharmacotherapy approaches implemented by clinical pharmacists versus usual care, which included physicians or advanced practice providers for the management of type 2 diabetes in patients that were on basal insulin at an FQHC. And as you can see here in this red box, the most common pharmacotherapy approach implemented by usual care providers was basal insulin titration, while clinical pharmacists most commonly added non-basal insulin. Additionally, usual care providers most frequently added metformin and sulfonylureas, while clinical pharmacists most frequently added prandial insulin, DPP-4s, GLP-1s, and SGLT2s. However, the study was conducted in 2019, only shortly after these agents were incorporated as first-line therapies in the guidelines. Therefore, the purpose of this study was to compare the rates of patients receiving a first-line pharmacotherapy to determine whether low prescribing rates is an existing potential barrier to achieving glycemic goals at an FQHC clinic. The study was conducted at the Erlanger Community Health Centers in Chattanooga, Tennessee, and the clinics are staffed by both academic and non-teaching services, in addition to one clinical pharmacist. In the year of 2022, nearly 14,788 patients were seen, and 26% of them were uninsured. There is an embedded 340B pharmacy that is able to provide medications at a reduced cost to our patients. And additionally, there is at least one agent from the SGLT2 class or the GLP-1 class on formulary that provides access to these medications to our patients. Primary outcomes included rates of patients prescribed a first-line therapy and the mean change in A1C from enrollment. Secondary outcomes included types of pharmacist interventions, clinic attendance, optimization of non-insulin medication doses, total daily units of insulin, and percent of patients achieving a goal A1C. This was an IRB-approved retrospective study, and patients were identified through a report generated in the electronic health records, and then data was collected via chart review. For our statistical analysis, categorical variables were analyzed with a chi-square or Fisher's exact test, and numeric variables were analyzed via student t-test. So we included patients with a documented type 2 diabetes diagnosis who were 18 years or older and had a documented A1C of 9 or greater between January 2021 and August 2022. We did, however, exclude patients with type 1 diabetes, gestational diabetes, patients who were pregnant, or who had an encounter with endocrinology for the management of diabetes within the previous year, or those patients who had not seen a PCP in the previous 18 months. 389 patients were identified. Of those, 305 were managed by usual care, which included a physician or an advanced practice provider. And 84 of them were managed by a clinical pharmacist. After exclusion, 67 patients in the pharmacist-led group were eligible for inclusion. And we elected to only include 67 patients of the usual care group in order to maintain an equal size cohort. Now, for the demographics of our patients, I just want to point out that patients in the usual care group were older compared to those in the pharmacist group. Additionally, some notable findings include that there were more white or Black patients in the usual care group, as well as more patients with commercial or government insurance. In the pharmacist-led group, we had a larger population of Hispanic patients and patients who were uninsured. There were more documented allergies to metformin, SGLT2s, or GLP-1s in the pharmacist-led group, in addition to more documented hyperglycemic symptoms. The most common comorbidity among both groups was hypertension, and over half of our patients were obese. And majority of patients were at high risk for ASCVD, and about a third of them had a history of an ASCVD event. There were no differences in contraindications to non-insulin agents or baseline labs. Moving on to our primary outcomes. So I first want to orient you to the two different groups on this chart. And throughout the presentation, you'll see that patients in the usual care group are denoted by this dark navy blue color, and patients in the pharmacist-led group are denoted by this gold yellow color. So at enrollment, there were no differences in the rates of patients prescribed first-line therapies. However, at the end of the study period, more patients in the pharmacist-led group were prescribed a first-line therapy. We also found a statistically significant difference in the mean change in A1C between the two groups. So by the end of the study, patients in the pharmacist-led group had a mean change of 3% from their baseline A1C compared to 1% in the usual care group. Throughout the study period, patients in the pharmacist-led group consistently had a lower mean A1C, as is indicated by the red marker on the graph, with a statistically significant difference in the mean change between the first and the third subsequent A1Cs. At the end of the study, more patients in the pharmacist group reached an A1C less than 9%, and more patients also reached an A1C less than 7%. So as I previously mentioned, the clinic's A1C goal per the HRSA quality metrics is less than 9% in order for the clinic to receive grant funding, but we also take patient-specific A1C goals into consideration. Taking a closer look at the specific agents prescribed, most of the patients were on either metformin or insulin. However, more patients in the pharmacist-led group were prescribed an SGLT2 or GLP-1, despite having a larger population of uninsured patients. Also, more patients in the usual care group were prescribed a sulfonylurea. Of these agents, pharmacists most often optimized SGLT2 doses. And I do want to note that during the study period, we did face a shortage in GLP-1 agents. Therefore, the up-titration of our GLP-1 agents was halted due to the shortage. We also saw that the average number of PCP appointments among both groups was 9, with an average number of pharmacist appointments of 4. And there were more patient canceled or no-show appointments in the pharmacist-led group, and there were no differences seen in the total daily units, in the change of total daily units of insulin. The most common pharmacist interventions were dose titrations and starting new therapies. So to summarize, what we found from this study was that pharmacist-led diabetes care in an FQHC was associated with improved glycemic outcomes with higher rates of prescribing first-line therapies despite more patients being uninsured. So time for our self-assessment question. Does a pharmacist-led diabetes management program at an FQHC increase prescribing rates of first-line therapies. Yes, no, yes. So I'd like to thank all the members on this research team for their assistance. And thank you all for having me, and I'll take any questions that you guys may have. Yes, Kyle? Why do you think you found more documentation? So I'll say our pharmacists at Dodson have a lovely template, which includes documenting hyperglycemic symptoms within their progress notes. It was very hard to find any documented hyperglycemic symptoms in the usual cares. I think it's just related to lack of documentation on the provider side. Yes, Brittany.
With the pharmacist intervention group having larger incidence of self-pay patients or patients how do you think that influenced still having a much more significant decrease in the average A1C, since those patients would be less likely to be able to access first-line therapies?
I think it's the time that our pharmacists are able to spend helping the patients fill out the patient assistance programs, getting them coupons, in addition to like the close follow-up. I think that all helps with patients not only being on appropriate medications, but just continuing having a better adherence to the medications with such close follow-up. Yes, Austin?
I think it's interesting that you showed a difference of no-shows in the pharmacist-led group. You already saw the difference between the two patient groups, but is the actual difference larger than what was seen because of the difference seen in the no-shows? So you weren't able to evaluate those patients that didn't show up. And I guess that could be a barrier to care if patients don't think that, pharmacists have much benefit over what their physicians can.
Yeah, from what when I was doing my chart review, it seemed that most of the no-shows were upon the initial referral. So that very first appointment, it took patients a couple of calls in order to get them to show up for their first pharmacist appointment. So I think that also contributed to those rates. Okay, thank you.
Thanks. No, good job. All right, next up we will have Dr. Jessica Duke. Reverse alphabetical order.
All right. Well, thank you for that introduction, Dr. Hollums. My objective for this presentation is to compare the total duration of antimicrobial therapy in hospitalized patients with misdiagnosed UTIs before and after adoption of an active antimicrobial stewardship intervention. I have listed some definitions for some abbreviations that you will see throughout the presentation. And I have nothing to disclose in regards to anything related to the presentation. Just some background before we get started. So UTIs are frequently misdiagnosed, leading to inappropriate antibiotic prescribing. And this is likely due to heavy reliance on urinalysis and positive urine cultures in the absence of urinary symptoms. ASB and pyuria are common among hospitalized patients. However, antimicrobial therapy is usually not warranted according to the IDSA guidelines on asymptomatic bacteriuria, where they only recommend treatment for pregnancy and those undergoing endourologic procedures. And this is because treatment of ASV has been shown to not be helpful and may lead to harm. And so the treatment of ASV has been identified as a major target for antimicrobial stewardship programs. So the purpose of this study was to examine the effectiveness of an active antimicrobial stewardship intervention on decreasing duration of inappropriate antimicrobial therapy for misdiagnosed UTIs. Our primary outcome was our duration of antimicrobial therapy, and this was in days. So if a patient received even just one dose of an antibiotic, that would be considered 1 day. Secondary outcomes include hospital length of stay, all-cause mortality, 30-day all-cause hospital readmission rates, 90-day incidence of C. diff infection and multi-drug resistant organisms, and then any antibiotic-associated adverse event. The study was conducted at Erlanger Health System. We're a level 1 trauma academic medical center located in Chattanooga, Tennessee. We have approximately 800 adult beds, and we have a progressive antimicrobial stewardship program where our ID pharmacist, myself, and our ID physician work very closely together. The methods of the study, so our actual policy for automatic discontinuation of antibiotics for asymptomatic bacteria or misdiagnosed urinary tract infections was approved by P&T committee in 2017. We then obtained IRB approval for our retrospective study. Patients were identified through pharmacist intervention documentation and diagnosis of UTI in those without documented acute urinary symptoms, and we did that through thorough chart reviews. We also used propensity score matching to reduce risk of confounding bias. Continuous data were analyzed using Wilcoxon rank sum or a 2-sample t-test, and our categorical data was analyzed through chi-square or Fisher's exact. Now I want to talk about our 2 study groups real quick, and particularly want to hone in on what our intervention actually does. So this is a unique antimicrobial stewardship intervention in which it allows pharmacists to automatically stop antibiotics for misdiagnosed urinary tract infections. And so we work very closely with our ID attending, and we review all patients that have an antibiotic ordered for the indication of a urinary tract infection. And so we require that an indication be provided for all antibiotic orders used in the hospital so that we can easily identify these patients. We then do a thorough clinical review for documentation of acute urinary symptoms in the chart. And then if no acute urinary symptoms are found, or the patient, and the patient doesn't look infectious, we then can automatically stop antibiotics. And then in addition to this, we will place a note in the patient's chart just to notify the provider that antibiotics have been discontinued and to document the intervention. And so these were the patients that was in our intervention cohort. We compared those patients to our historical cohort. These were just patients that received an antibiotic order for a UTI in the absence of acute urinary symptoms. And so we identified these through looking through reports from our electronic medical record, who identified patients that had a UA ordered and a discharge diagnosis of UTI. And so during this time, there could have been recommendations made by the antimicrobial stewardship team to discontinue antibiotics. So for this analysis, we included patients that were 18 years or older, had a UTI diagnosis, but no documented urinary symptoms. We excluded patients in the ICU, those that were pregnant or incarcerated, patients with a history of renal transplant, those receiving antibiotics for another infectious indication other than UTI, and then those with urinary catheters. For our baseline demographics of our patients, this is our total cohort. So this was before propensity matching. You can see that the majority of our patients were females. Around 80% of patients were females. And then these were elderly patients with a median age of 72 in the control and 75 years in the intervention. Between 40 to 50% of patients in each group had altered mental status at antibiotic initiation. And you can see here I have listed chief complaints of these patients as well, with common ones being altered mental status, fall, generalized weakness, stroke-like symptoms, etc. Additionally, I have important infectious baseline demographics as well that we looked at, including white blood cell count, temperature, heart rate, and respiratory rate, which were all within normal limits between groups. It's important to note that less than 10% of patients in either group met SIRS criteria. And so it's just important to remember that almost all septic patients will have SIRS criteria, but not all patients with SIRS criteria are septic. Additionally, we looked at pertinent urinalysis findings and findings from our urine culture. So the majority of patients had significant pyuria, which is just our white blood cells in the urine. So in the control group is about 85 compared to 65 in the intervention group. Between each group, greater than around 75% of these urine cultures did reflex. So at our hospital, we do have a urinalysis reflex to culture policy. So any urinalysis with more than 10 white blood cells, less than 5 epis, or in the absence of bedding yeast will all reflex to culture. Most common urinary organism was E. coli, by no surprise, and you can see others there. And between 10% of these urine cultures were actually contaminated. So as I previously mentioned, we did do propensity score matching to reduce the risk of confounding bias within our group. So before our propensity score matching, we had 229 patients in our intervention group and 77 in our control. And then after matching, we had 70 patients in each group. So moving forward, all of the outcomes that I will be presenting will be those from the propensity score matched groups. So our primary endpoint again was inappropriate antimicrobial days. As you can see in the post-intervention cohort, that median duration of therapy was 2 days compared to 6 days in our pre-intervention cohort. And so Bonferroni correction was applied to adjust for a number of tests performed. So p-values less than 0.007 are statistically significant. So you can see this was not only clinically significant, but also a statistically significant result as well. Additionally, looking at our secondary outcomes, there were no differences in secondary outcomes with the exception of hospital length of stay, where it was 6 days in our intervention group compared to only 4 days in our control, which at first I was a bit surprised by this, but it seems like this could have possibly been due to premature closure in our control group. If patients come in and they get diagnosed with a UTI inappropriately and get sent out the door compared to patients that were actually doing, monitoring longer and maybe finding the true cause of what's making them sick. And then in our intervention group, this just could have been due to selection bias as well. The longer that patients are in the hospital, the more likely we are to identify these patients and make recommendations. So finally, for our discussion, I just want to close by saying, UTIs are commonly misdiagnosed in hospitalized patients. Our study showed us that patients that are particularly at risk for this are our elderly females with altered mental status. Antibiotics were restarted by the primary team in approximately 7% of cases. And this was not just in our propensity score match group, this was total. So of the 229 patients that we intervened on, only 7% were restarted on antibiotics. And so this showed us that our active intervention was safe at decreasing inappropriate antibiotic days for misdiagnosed UTIs. And there were no statistically significant differences in safety outcomes between groups. So this was not only an effective intervention, but also a safe intervention. And finally, I have a case to close out my presentation. So we have patient AE. This is an 80-year-old female with moderate dementia. She came into the emergency department from her long-term care facility because of lethargy. She is confused, but she denies cough, fever, abdominal or back pain, or urinary symptoms. Her labs and vitals are stable and within normal limits, but her UA is positive with large leukocyte esterase and pyuria. A urine culture is pending, And the primary team initiates her on Rocephin 1 gram for acute cystitis. What is the best course of action to be taken for this patient? Should we recommend changing antibiotics to nitrofurantoin 100 milligrams twice daily? De-escalate antibiotic therapy once urine culture results? Stop ceftriaxone and monitor off antibiotics? Or escalate antibiotic therapy to meropenem? I think I see C out there. So yes. As you can see, she has lethargy, so that's very non-specific symptom. She denied urinary symptoms, even though her UA is positive, so we should stop antibiotics. I'd like to thank my co-researchers and our statisticians for all of their help throughout this year for this project. Couldn't have been done without them. And with that, I'll take any questions that you may have. Okay. Thank you, doctor.
And lastly, we will have Dr. Jessie Briscoe.
Hi, team.
No, you. Megan. All right, and Dr. Briscoe will be presenting on the comparison of glycemic control in basal versus basal bolus insulin regimens in a medical intensive care unit patients on continuous tube feeds.
Hey guys, I'm excited to talk to you about my research. Before we get started, I'd like to note that no one associated with this project has anything to disclose. My hope is that by the end of this presentation, you're able to compare the safety and efficacy of basal versus basal bolus insulin regimens in medical ICU patients on continuous tube feeds. Before we get any further, I do just want to describe the differences between these two regimens. So basal regimens in our research project were defined as a long-acting insulin, so like a basal insulin with a sliding scale insulin. And then a basal bolus regimen would be a long-acting insulin, again with a sliding scale insulin, but it also includes a fixed bolus dose at a scheduled interval. So that would be like regular insulin, 5 units scheduled every 6 hours. So the big difference between these two groups is just the presence of that fixed bolus dose or not. To give you some background on this topic, we know that the prevalence of hyperglycemia can be as high as 46% in ICU patients, and hyperglycemia is independently associated with increased mortality in our hospitalized patients. So insulin is commonly utilized to maintain glycemic control and also improve patient outcomes. There is significant literature regarding optimal insulin regimens in patients who have traditional diets, but literature is more limited for patients who require continuous tube feeds. The American Diabetes Association recommends that patients requiring insulin on enteral tube feeds should have a regimen divided into basal, bolus, and correctional components. And the interesting thing about that recommendation is that it doesn't actually specify whether it applies to patients who are on bolus-based tube feeds or continuous tube feeds. It's just a general recommendation. So I think that that recommendation makes sense for patients who are on bolus-based tube feeds, that given that the patients are getting a significant increase in glucose at one time, which kind of mimics the peak and duration of prandial insulins or bolus dose insulins. But it might not make as much sense for patients who are on continuous tube feeds. So a regimen that includes a bolus-based regimen with a continuous infusion of insulin without a pronounced peak more closely mimics the continuous infusion of carbohydrates that patients are receiving with continuous tube feeds, which might make more sense. So basal and correctional only insulin regimen is commonly utilized in our patients who are on continuous tube feeds rather than a basal and bolus-based regimen. So the goal of this study was really to compare our basal and basal bolus groups in terms of our primary outcome, which was glycemic control. And then we also wanted to assess our rates of mild hypoglycemia, our rates of severe hypoglycemia, the incidence of hyperglycemic emergencies such as DKA or HHS, and then also glycemic variability. We define glycemic control as mean blood glucose, and then also assess percent of blood glucoses within target range when assessing glycemic control as well. In terms of our target blood glucose, we wanted that to be between 70 and 180. Hyperglycemia was defined as a blood glucose greater than 180. Mild hypoglycemia was defined as blood glucose less than 70, and then severe hypoglycemia was defined as blood glucose less than 40. Finally, glycemic variability was defined as the standard deviation of mean blood glucose. This research was conducted here at Erlanger, which is an academic medical center that serves as a tertiary referral hospital for the surrounding area. It includes 7 intensive care units, and our medical ICU patients are managed exclusively by our pulmonary critical care service, which also has a rounding pharmacist. In terms of methods, we started by obtaining IRB approval. We then identified patients with concomitant orders for both basal insulin and tube feeds, and then screened patients for inclusion and collected data via chart review. All of the statistics that will be presented today are descriptive statistics, as we're still waiting on our actual statistical analysis to come back. Patients were included if they were at least 18 years old, admitted to the pulmonary critical care service, if they had an active order for continuous tube feeds, and then also an order for insulin detamir of at least 20 units daily. Patients were excluded if they received oral hypoglycemic agents during the study period, if they were admitted with diabetic ketoacidosis or hyperosmolar hyperglycemic state, if they were diagnosed with an insulinoma or pancreatic tumor, if they received oral nutrition during the study period, or if they had end-stage liver disease. So in total, we included 100 patients, a sample of all the patients that were assessed, and ultimately had 50 patients that were in each group. When we look at age, this was similar as was sex, so there were slightly more males in our basal bolus group. Body mass index and history of chronic kidney disease were also similar between the two groups. The basal bolus group had slightly more patients who had a history of diabetes and had a higher A1C, and more of the patients in the basal bolus group were on insulin prior to admission. When we look at our hospitalization details, there were no differences in terms of hospital length of stay. The basal bolus group had a slightly longer ICU length of stay. The in-hospital mortality was rather similar between groups, and then we followed patients for a similar number of study days between both groups as well. Now moving on to the differences in the insulin regimens between the two groups. So in terms of total daily insulin dose, the basal bolus group received almost 30 more units of insulin per day when compared to the basal group. 9 units of that was attributed to their long-acting insulin, with the rest of it coming from their bolus dosed insulin. And then in terms of percent of long-acting insulin doses held, this was rather low in both groups. Sliding scale was similar between our two groups. And then when we looked at our daily bolus dose for our basal bolus group, it was about 20 units a day, and 18% of the scheduled bolus doses were held, which I thought was interesting. So for our long-acting insulins, our nurses have clear protocols on when to hold, and they have to contact our providers before they hold those long-acting insulin doses. But for bolus-based insulin, we actually don't have a clear protocol. So all these doses were held at nurse discretion. They could choose to speak to the provider if they wish before, but lots of times they were just making that decision based on their clinical judgment and their patient's clinical status at the time. We also assessed the administration of tube feeds and steroids. So daily carbohydrate load was similar between the two groups. Both groups actually had rather low percent of days of tube feeds held. And then steroid administration was slightly higher in our basal group, but daily prednisone equivalent dose of the patients who did receive steroids was similar between groups. Now moving on to our primary outcome of glycemic control, when we assessed average blood glucose, you can see that it was slightly higher in our basal group when compared to our basal bolus group, and neither of our groups achieved our target blood glucose range on average of 70 to 180. Both were slightly higher than we would have liked. Now we'll look at blood glucose checks in range. So this is all listed on the y-axis in terms of percent of blood glucose checks. And you can see that both groups had rather low rates of mild hypoglycemia. The basal bolus group had a higher percent of blood glucose checks in our target range of 70 to 180 than our basal group. And then our basal group had more percentage of checks greater than 180 in our hypoglycemic range than our basal bolus group did. When we assessed our secondary outcomes, I wanted to highlight that we collected over 2,000 blood glucose checks in each group, so over 4,000 blood glucose checks total. So we were assessing a lot of information despite only having 100 patients included in the study. In terms of mild hypoglycemic checks, so blood glucose less than 70, the two groups were quite similar. In terms of severe hypoglycemic checks, there were slightly more in the basal bolus group, but 4 versus 1 when you're looking at over 4,000 checks is quite low for both, actually. And then in terms of hypoglycemia requiring treatment, the two groups were quite similar. Finally, when we assess glycemic variability, it was slightly higher in our basal group versus our basal bolus group. So based on the information that we have right now, while we're waiting our final statistical analysis, it appears that the basal bolus group was associated with improved glycemic control and less glycemic variability than our basal only group. And the basal bolus and basal only groups had similar instances of hypoglycemia. Approximately 18% of our bolus doses were held at nurse discretion in our basal bolus group, which I think indicates for us that there's an opportunity to standardize when it's appropriate for our nurses to hold those doses versus administer bolus doses so that we can try to achieve glycemic control but limit our instances of hypoglycemia as well. So my self-assessment question is true or false. The ADA recommends utilization of a bolus-based regimen consisting of basal, bolus, and correctional insulin components for patients who are on continuous tube feeds. The answer to that is true. I'd like to acknowledge my co-investigators, and now we'll open up the floor for questions. Any questions? No? Oh, Brittany? Yeah.
About the 18% of health doses, bolus doses that were held. Did you look at differences, excluding the patients who had the health doses? Do you feel like there would have been a difference if you excluded that significant?
Yeah, so Brittany's question is, did we think about excluding patients who had bolus doses held? And the answer to that question is no. So actually one of the reasons that our providers like the basal bolus approach, even in patients who are on continuous tube feeds, is that they feel that if you give a patient only Levemir, let's say, and then their tube feeds are held or they have to go to the OR for a procedure, you've given them this massive amount of insulin and there's not really anything that you can do to stop it. It's going to hang around on them all day long. So you'll have to worry about starting D5 or paying more attention to their blood sugar. Whereas if you split things between basal and bolus, you have a little bit more wiggle room if tube feeds get held or if they have to stop their tube feeds or whatever infusion of dextrose for some reason. So they actually like that the nurses can hold it. So that way, if something changes in the patient's status, they don't have to worry about a large dose of Levemir that's not going to wear off for a really long time. So I think that's one of the beauties of a basal bolus regimen, even though it doesn't quite as closely mimic the continuous infusion of carbohydrates with continuous tube feeds. So I think that it's a good thing for us that our nurses can hold that and potentially better for the patient. It's just a matter of standardizing it so that we're consistent when we're holding those doses versus when it's appropriate to give them.
The second part of that question, plan to provide education needs outside the ICU as to how to transition from these types of basal bolus regimens to a more granule type of basal bolus regimen as these patients start eating after transition. Is that part of the next steps in planning this process?
Yeah, so Brittany's second question was, are we planning on doing education with our teams that are receiving these patients on these unique basal bolus regimens when they've been on continuous tube feeds so that they can appropriately transition them once they start eating or change to bolus-based tube feeds? I think that's a great idea and something that we really should consider for our floor medicine teams, since this is kind of a unique approach that's newer in our terms of insulin management. So we can definitely look into that. Chris. Yeah, so Chris's question is, do we have a plan on how we're going to standardize? As of right now, no, I think that's going to be something that we'll have to work with our critical care physicians on to determine what they think is the most appropriate. The problem that we run into a lot now is that someone's blood sugar will be 120 and they'll have their next dose of bolus insulin due, and our nurses will hold it because they're concerned that it will drop their blood sugar. But the reason that their blood sugar is where it is because they got the previous bolus dose 6 hours ago. So when it's held, when they're at 120, sometimes that causes the patient to go hyperglycemic again, and then we kind of get behind on our insulin regimen. So I don't know if it'll look like a blood sugar less than 100 gets a bolus dose held, or if its physician needs to be contacted before the bolus dose is held, but hopefully we'll come up with something that's reasonable for all parties involved. Any other questions? Okay, thanks, guys.
Alrighty, everyone. That concludes our symposium today. And let me pull up the claim slide for you all. There is your CE code for today. Yes, fantastic job to all of our residents. Good luck at CERC this weekend.